Welcome to Healthcare Rounds. Thanks for spending a little time with us today on Healthcare Rounds. I'm super excited. I've got Matt Portch here, and this is really the start of, we'll say, several discussions that I'd like to have around pharma, the pharmaceutical industry, and sort of where they are today. And most of the topics that we've been talking about here on Healthcare Rounds have very much so a triple aim focus, or quadruple aim or quintuple aim, if that's sort of your flavor. And we're going to be sticking to that in some of the conversation that we're having today. It's just that most of those who've been listening to Healthcare Rounds for a while know that there's kind of a general talk. Today, I want to talk a little bit about some of the trends that are happening in the health system space, but then really get to the pharma perspective, which is something that I haven't done in a really long time. And having Matt Portch here is, I can't think of a better expert to have on to have this conversation. Matt and I have done a little bit of work together, but are really looking to do some more work together. And as we were looking at potential projects and things, I asked him, I said, Matt, can we some of the things we've been talking about, can we do Healthcare Rounds? And he graciously accepted. So Matt, thank you so much for taking time today. And maybe just by way of introduction, talk a little bit about your background.
Yeah, thank you, John. It's a pleasure to be here. Really happy to join you. Having watched some of these, it's now the extra pressure to be on camera, so to speak, and
No
being
pressure.
recorded. But it's a pleasure to be here. And John, as he mentioned, we've had some discussions, and I'm really passionate about this space, John. And you talk about background. I spent 38 years in the pharma business, a lot of traditional roles, but the last 15 or so have been either developing or leading account management teams, specifically around IDNs. I've also done a lot of work around payers as well. But I had the great fortune, my last 5 years at Pfizer, to build the CAM team. What we identified was the challenges and opportunities going on with IDNs and health systems, where we weren't performing as well as we were with our traditional marketplace. So we built a CAM team up, and I'm really pleased to see that since I left the organization, they've gone from 60 CAMs to 300 across their 6 BUs, and continue to be number one rated within the industry. So it's great about that. After I left Pfizer, I went to Sunovion, where I was a senior vice president of sales and market access. And we built an IDN team there as well, certainly not as large as Pfizer because of the resources. And so I had the opportunity again to build it from scratch and see and learn kind of what worked and a lot of what didn't, by the way, as you do this kind of a thing, and learned a lot from our customers as well. And then the last 3 years, I've been doing some independent consulting, almost all around IDN and key account management as well. So I've been able to see, number one, what other companies beyond the few I've worked for have been doing, as well as spending more time actually learning from customers about kind of where their needs are as well. And that evolution, which I know myself and John, we've talked, maybe you thought this was going to happen much faster. I mean, we started talking about healthcare reform 10 years ago, but we're reforming and continuing every day. Our customers continue to reform. Value-based care isn't where we thought it was going to be, but it's getting here as one example. But, again, I'm excited to be here because of the background of what I've done so far. And there's a lot more to do, I think, that pharma can really do to partner, so to speak. And we'll talk, I think, more about what partnering really means. But with our health systems and IDNs, to do a better job of providing better patient value. And a little bit selfishly, I'd like to see pharma do just a better job of improving the reputation by delivering more value to our customers that way. So,
Matt, you're one of the few people that I know that would say that you're passionate about this stuff, because I feel the same way. But I don't run into a lot of that in pharma. That I'm passionate about the changing healthcare environment. I'm passionate about health systems and some of the movements that have been happening. Passionate about following what's happening with Amazon, and right. I mean, a lot of people I talk to, that's a headache.
Yeah,
it's a headache. That's something else that I have to deal with, right?
Yeah, it is, and I get it. I was quote an old timer in pharma as well, right? But like any business, right, you've got to really follow your customers, right? And when I say follow, very closely as they move and evolve to where they're going to be and how they're reimbursed and what they value. It's not different than what's been happening before within pharma, but I think it's more dramatic, and that's the difference.
Yeah.
The changes are more dramatic because the decisions are made in a different place by different people than they have been in the past. It's not always just the physician nowadays, right? Where before the physician's priorities may have changed, and we adapted to those changes, but now you've got upstream committees that are making decisions, IDNs and health systems creating their own formularies or protocols, and that's just very different for some people to wrap their head around, I guess. So, but ignoring it is much worse than trying to evolve with it. That's for sure.
Of course. I was thinking for a couple of, we'll say, seasoned people, as you and I are seasoned, right?
Mm-hmm.
Do you get the feel, I was thinking about this on the plane the other day, do you get the feeling that this is reminiscent of like early 90s managed healthcare, how pharma was reacting to the sort of proliferation of health plans and, with, having much more control over where your drug, like, do you get a sense, and it may not be a perfect parallel, but that there's a similarity to where we are with IDNs today to maybe where we were in the early 90s with managed healthcare?
Yeah, I think that some people still see it as, is it a fad, so to speak, right? Is it something that will be long lasting? How will it really impact people? And it's interesting to bring that up. One of my first jobs in account management was with BMS in the payer world when we were just learning how to spell HMO. I mean, it was very early in 1990, and at least at that organization, and I think others as well, we watch our competitors. I think everybody's first inclination was, let's figure out how to stop it or minimize it, but not really deal with it. And then, I mean, hindsight, right? Everybody rebates, or almost everybody does. Everybody's working with the payers. It's become the norm of how we do business, but it took some time for people to do that. And I think we're at that situation now with health systems and IDNs. And another thing too, John, and I don't want to disrespect senior leaders at large organizations, but one thing that I've seen where I worked, and then even more so in my consulting world, is that the further away you get from the customer, the less people have a sensitivity what's really how dramatic the change really is in the marketplace. You talk to people that are customer facing and they see it every day, they feel it every day. They may not tell you exactly what's happening, but they know that the relevance may be dwindling with their messaging. I mean, you talk to reps who can't get into offices or get very little, if any, time. But even when you talk with leaders that are closer to the customers, I think they're feeling that need for change more maybe than people that are further away, and get kind of locked into the very important job of running the business, but not being really customer facing.
Yeah, and I think it's easy to, listen to me speak for the CEOs of big pharma, but I mean, it's easy to be focused on quarter to quarter earnings. This is the way that we've always done it. This is proven again and again. This is what works. You have the same consultants chirping in their ear. You got a product launch coming out. All right, this is exactly what you need to do. And I remember, back in that same time frame, my first in-house corporate, if you will, job at Abbott was market research analyst in managed healthcare, and it was a brand new unit, brand new, and just trying to determine, like, well, is it, like, to your point, is it here to stay? Is it a fad? And then, kind of getting their legs under them and seeing, okay, well, this is the way we're going to have to do business. And over, I don't know, a decade or so, things kind of evened out and made their adjustments. And now here we are with health systems and these IDNs and some companies. You gave the Pfizer example, putting together that team and looking at where they are now. Some got involved earlier. Some are still kind of making the decision, well, how much energy and effort do we put behind these folks? And that's actually a good transition, I think, to talking about our first trend. And I'm gonna ask you about trends, but this one is sort of self-evident, and it's been around for a while. And that's this notion that health systems are cash strapped. They're not doing well financially for a variety of reasons. We can blame supply chain, we can blame COVID and aftermath of that. But we both know that health systems have been struggling financially for a very, very long time, at least in terms of posting the kind of numbers that they would like to post year after year, even not for profit, right? I mean, if you don't run your not for profit like a business, you've got a problem. Everybody knows that. So, what is it about? I guess my question is twofold. What is it that you're seeing financially with these health systems, understanding that they're not all, of course, all underwater? And then back to today's conversation, we're going to try to bring everything to pharma. What should pharma's response be? So what is it that you're seeing, and then what's a good appropriate response?
Yeah, great question. And I think, and I love the second part of that question, right? Because one of the things that I've learned over time doing key account management, whether it's payers or IDNs or health system, whatever, is you have a deep understanding of your customer's business, right? And so, one of the things we're seeing, and you see this as well, I know, John, your work, right? They're looking to figure out how do they improve margins, right? So is it through M&A growth? Is it through vertical integration, horizontal integration? We're seeing a lot more of more efficiencies, right? More outpatient things being done, site of care, getting things out of the hospital where it's very expensive is happening as well. Quality metrics, trying to hit quality metrics. There's a lot of them are struggling with just hiring clinicians, right? But I share all those things. I think as a key account manager, I've got to know and understand my customer and all those things that are shaping their behaviors. And then, but what are the things that I can really do something about, right? I'm probably not going to do a whole lot about their M&A activity or their, maybe their lack of clinicians, other than maybe, helping with clinician education or something. So it starts with, all the things that are really important to them. From a pharma perspective, it's really probably around margins, total cost of care, and patient experience, right? Those are things that I know if I've got good products and good value propositions that go along with those products, that I can probably help the customer with, right? Versus all those other things. I need to understand them, but I have to think about what are the things that the customer cares about that I can do something about. And that overlap is not going to be anywhere near 100%. Because pharma, we like to tout we're 10 to 15% of the healthcare dollar, which means that 85 to 90% of the healthcare dollar and the health system is spending their money somewhere that we don't impact or can't impact as much. So it's understanding those. And I think that, to your point, I saw something just recently. I think 9 of the 10 largest health systems were underwater last year. But from my reading, I think people are in a better position now. But
Agreed.
they're still going to continue to struggle, right? And I do think one of the things important for pharma, and particularly for someone who is a key account manager that owns some of those customers, is knowing where your customer is on that financial health, right? Are they the buyer? Are they going to get bought? Are they, where are they struggling? Are they a value operation or a patient care and quality operation? Because that'll drive some of their decisions and behaviors as well.
Well, it was interesting. You rattled off a bunch of things with respect to finances that are almost like trends unto themselves, right?
Yeah.
I mean, supply chain issues, that's an issue, that's a trend, but it affects finance.
Yes.
Hiring or spending, your budget on travel nurses versus having full-time nurses, right? That's obviously going to affect your budget. So what I heard and I agree with is, number one, you have to understand the environment,
Yes.
your customer's environment. Even if you can't do anything about those things, you need to understand where they're coming from. And I know I'm kind of jumping ahead here. I'm going to bring us back to the trends here in just a second. But it's important because, I think sometimes people, and again, I'm skipping ahead, but sometimes people in that account management role, they think about, okay, they think inwardly, and then what is it that I have to offer? And then how am I going to have a conversation about this person without doing all that legwork first to really understand really where that customer is or likely where they will be. I mean, you'll never know until you start having a conversation and probing and all of that. But
Right.
having that, and then saying, okay, well, if the issue is, for instance, workflow, don't bring a partnership idea or something to the table that is going to significantly affect workflow in a negative way, right?
Exactly.
Because that's just going to affect margins. It's going to affect all the people there. So, yeah, I mean, but so let's go back to the trends, and then I want to get to something that I think we've both been thinking a lot about, which is AI, and we know that it's there. We know it's what everybody seems to want to talk about these days, or certainly this year, ChatGPT and all of that. What is your sense of how IDNs have been approaching this sort of new AI? And again, I'll bring it back to pharma. And are there ways that pharma can help, maybe either through their own AI kind of work, or or is there a role as AI starts rolling out into these systems? So maybe talk a little bit about that.
Yeah, it's interesting too, John, and I've probably heard this thing from you. I've heard that moniker so much in the last several months, right? Everybody was talking with a pharma client recently. He said, "Well, tell me about all the AI trends," right? And like, well, what do you mean all the AI trends? Where do you want to go, right? And I think we see this with the IDNs and health systems as well. I think everybody is looking at this as an answer. The question is going to be, how is it going to be the answer, right? It's not going to be anybody's silver bullet, but how are they going to use it? And from what I've seen so far, I think people are just still trying to wrap their arms around what they can do with it, right? I mean, if you look at our customers as an example, health systems and IDNs, yes, I know they all have AI initiatives, but if you look at kind of how they're implementing care at the front line between the physician and the patient, a lot of that is still, they're still struggling to implement and really effectively use their EMR as an example, right? Which is just a basic step-by-step tool. Input the data, and then you maybe get some suggestions or recommendations on next steps. But it feels like right now they're still inputting information versus really learning from it or getting really evidence-based care protocols out of that. I know some customers are further along than others, and I think that'll eventually come. And I think everybody does believe, everybody I've talked to at least believes that we're going to have more technology-based recommendations around care. That makes sense. Just the question becomes when, how they do it, and then how it gets implemented. And then I think they have the human factor, right? What is the clinician at the end of the line going to do or not do about that as well? So, and then you have to get the patient to, patient behavior is still the majority of what drives their diseases and their side effects and, compliance and adherence to the medication, healthy lifestyle. AI is not going to change any of that, unfortunately.
Yeah, probably not. And a couple of points bear repeating.
Yeah.
A lot of these systems, and I would even say the vast majority of these IDNs, and they'll readily admit this, are not fully capitalizing on the EHR, on the tools, the ancillary tools, as well as the built-in tools for pop health. And a lot of that is just resources. Do they have enough people to be looking at the data, analyzing the data? So before we even get to the AI, let's just say the state of the state is the majority of these systems are underutilizing the tools that are already available to them, probably because of resource constraints. Would you agree with that?
I would agree. In fact, I would suggest I had my annual physical a couple of weeks ago, and I go to a pretty large, some would even say sophisticated system. And one of the things in the back near the nurse's station was a bank of fax machines. You probably can't find fax machines in many other industries today, but you still
Yeah.
will find them in healthcare, right? Maybe not used like they used to be, but they all had paper in them and two of them were going. So something was happening.
Yeah.
So
It's
yeah, I think there is a technology, and healthcare leaders will tell you. I've heard this at conferences. They understand that they're behind, financial institutions and retail and other large verticals that have moved quicker with technology than healthcare has. So I think everybody will agree with that.
Yeah, and I think, I mean, from what I've seen a lot of chatbot use,
Mm-hmm.
like when you're going into the system for the first time or
Yeah.
you want to have some certain questions. I've seen, little drips and drabs of what was it recently? I forget the name of the health system, but they had something like 99% diagnostic accuracy for lung cancer, specific types of lung
Mm-hmm.
cancer. So it could be improving that. So the little one offs, but I think that,
Yeah.
so if I were to characterize, and tell me if I'm forgetting anything, if I were to characterize the IDN trend or the IDN environment, um, you have a situation where mergers are going to continue, and some of those are localized, some of those are multi state. The most obvious recent one being Risant, right,
Mm-hmm.
with Kaiser and Geisinger. I'm still trying to get my arms wrapped around that one. Um, to your earlier point, either for horizontal or vertical integration, um, we have, on balance, stressed financial health systems, stressed financially, but getting better on the whole.
Mm-hmm.
Not as much as we saw in 2023, still pockets of issues. Um, Ways that they're trying to address that are um, through adding outpatient clinics, just in general looking for new revenue streams, or getting more out of the revenue streams that they have. Um, and I would say, on balance, kind of taking over, not taken over, but kind of taking over as the dominant way that healthcare is delivered and paid for in the US around these health systems. We're not there yet, but what is it? 70, what, 72, 73? What's the latest number? Percent of physician offices are either part of an IDN or part of a private equity group,
Yeah, yeah.
right?
That's I've seen the same number, and you're right. I think why they're not there, they're moving that direction, and they certainly have much more of a base and control than they had 2 years ago, or 5 years ago, or 10 years ago, and everything looks to be moving that way, right? Because also of risk, right? Because if you're going to carry risk, you want to manage all of it, which means you've
Sure.
got to have the vertical integration. So, yeah.
And one of the things, just anecdotally, that I noticed coming out of COVID um, was the systems that had a payer arm seemed to do a little bit better
Mm-hmm.
than those that didn't have that. Maybe because people weren't using services as much, and so that payer arm did financially better. Something that people don't often talk about, but these large systems have major portfolios, investment portfolios,
Mm-hmm.
and as the stock market goes, so does their investment portfolios.
Right.
And right now, we're in a very favorable environment, much more favorable now than we were a year ago.
Mm-hmm.
So it doesn't surprise me that if their 401k, if people's 401ks are up, but their investment portfolios are up, that's going to be boosting their numbers as well,
Right.
right? I
Makes
mean, just
sense. Yeah.
stands to reason. So
Mm-hmm.
the one thing that I left out in that you mentioned, and just in terms of trends, is, and we've been at it for quite some time now, which is this value-based care movement
Mm-hmm.
and measuring quality, getting paid for or dinged on quality,
Right.
either way. So that's another component. And so the environment that we're operating in, just to kind of repeat myself, financially strapped, but getting better, looking for new ways of delivering services, new ways of bringing in revenue, in an AI environment, or at least coming forward, but a reality of they could be doing much, much more with the data that they have but their resources are constrained in that way.
Mm-hmm.
So that's and becoming a much more controlling and more dominant player in the overall scheme of things. Did I get that about right? That's
That's
kind of
I mean, you know probably better than me, but that's what I'm seeing, Joe, as well.
okay.
And I think one other thing too, and I've been hearing more about this just recently, is we talk about the aging population, but it's not just aging from the perspective of a larger proportion of older people means more healthcare needs, but just the movement, the payer movement, right, from more people moving into the proportion of Medicare and
Right.
Medicaid versus commercial, because I think everybody's probably aware. I mean, commercial's the best payer if you're a health system or a hospital or IDN. Medicare, you might break even, and Medicaid, you're probably losing money, right? So, as proportions change, our customers are going to have to figure out how to manage their margins and their bottom line better, even with the same volume, because the reimbursement is going to be lower. So,
Yeah, no, that's a really good point. And
yeah.
I remember it's a few years ago. I'm trying to remember Michael. I'm trying to remember his last name. But in any event, home health guy, and he laid something out on his whiteboard. I was having a meeting with him, and again, this is probably 10 years ago, but it's still stuck with me. We were talking about the caregiver ratio.
Mm-hmm.
And I was like, what's a caregiver ratio? And he's like, well, it's something AARP talks about, but it's really, who the number of people that could potentially take care of you when you're older. And when you look at the projections for that, and some of that is, how as a society how we have evolved, maybe evolved isn't exactly the right word, but maybe 100 years ago, 50 years ago, we made sure that our parents stayed with us in
Right.
their old age, and maybe our kids stayed with us a little bit longer than they do now. And when the family fragments, and I don't mean that in such a negative way, but kids grow up, they move out, they move
Mm-hmm.
elsewhere, parents are elsewhere, more mobile. So just being able to care for these people,
Yes.
regardless if it's going to be under Medicare, which they all would be, we're facing a serious issue and how we're going to deal with an aging population that I don't know that we've really addressed and that we've really looked at in any kind of meaningful way. And hopefully, I think the technology is going to, I guess, help with some of those things, remote monitoring, AI, right?
Mm-hmm.
Some of the things because if you don't have enough people to take care of the people, then there's got to be some other way to do it.
Right.
Um,
We're also not
so
going to have enough beds, by the way.
exactly.
And those facilities will be shorthanded, both with places to put people and people to take care of them, dramatically. Probably, you're right. Yeah.
And something that we saw from COVID, and I could spin out into this. We could talk about this for a while, but we're not really set up to have a surge sort of mentality around taking care of patients.
No.
I mean, if all of a sudden, you're at an 80% bed capacity, and all of a sudden your numbers are really 130% capacity because you've got a surge, it's not really set up over the long haul to deal with that.
Mm-hmm.
So we may be heavy on beds in some measure at this point,
Yeah.
but then we might be light in another way.
Yeah.
So,
well, and definitely in the skilled nursing facility, I've seen some information like you shared as well, how underprepared we are, and there's not incentives, unfortunately, for the operators today to put more beds in, but when they need them, it'll be too late.
yeah. So let's shift,
Yeah.
and talk a little bit about the need for account management in pharma.
Mm-hmm.
So we're doing a hard turn to pharma.
Sure.
And let me just set this up in a way. So the typical pharma approach historically has been you have a detail rep,
Mm-hmm.
and that rep is trained to sell product, but also in whatever category, whatever disease area, they're trained to know their stuff. And the goal is really go in, talk to a doctor. I hate to be so crude, but hey, doc, will you give me your next 5 patients on this diabetes drug, this antibiotic, this cardiovascular, whatever, right?
Yep.
that's kind of the old school, old way. And I and for a variety of reasons, which I'm going to stop talking in a second, I want you to just talk about some of them. But for a variety of reasons, while there are places still for that model, it's shrinking
It is,
rapidly.
yes. Mhm.
And the opportunity, if somebody thinks, okay, well, we're launching a new drug and we're going to do that solely on this, physician communication plan and this rep selling plan, I just feel like the opportunities of doing that get smaller and smaller when you have an environment where the IDNs are really taking front stage. And so what we do know is that model, that rep calling on a doctor, detail rep model, just doesn't work in health systems. For the vast majority of those health systems, I would
Mhm.
say, in most areas of the country, it just doesn't work. And so there's an argument for moving to a different model where pharma engages with these larger systems. And engagement is kind of a word I use a lot. It's a loaded word, means a lot of different things. But recognizing that the focus or the type of customer, the type of person, I should say, or type of role is changing as well. So let's talk about that and the logic of why it's so important to shift your thinking. And this is really, I'm speaking to the executives out there that are making the call, they're making
Right.
these decisions.
Mhm.
So why is it that this model is changing and why it's so important?
Yeah, that's a really good question, John. And well, so I'll first start with one of the things when I'd mentioned, my role at Pfizer. They had individual marketplaces that created some CAM roles before we centralized it, and their number one job was to get reps back in. Right? It wasn't to do medical exchange to convince anyone or whatever. But I think what people were missing was, to your point, the first thing that we saw with a lot of these large systems was that administration looked and said, we need to be more efficient and we need to take all this time reps are spending with their doctors and give them that time to spend with patients, right? And we're going to get more patients through in a day. So a lot of them actually, kicked reps out, had policies that reps couldn't come in, right? So that it started with something that simple. But the second thing, which I think has not been as appreciated, is that these systems are vertically integrated or horizontally integrated. These efficiencies are because they want to create more centralized control, right? And it starts with some of the really big things, right? The way they buy for their hospitals or the way they pay their employees or whatever. But eventually it gets down into everything they do, including evidence-based protocols on how they treat certain diseases, right? Let's figure out what's the most cost-effective and clinically effective way to treat patients and build that into our system, right? Which can erode physician autonomy. So even if the rep can get in there, does he or she have the ability to convince the physician to prescribe X amount of medicines that they want, right? And it started with some very basic, blunt, report cards, percentage of generics or whatever. But now they're getting more specific where they're actually looking, and this is where I think that medicine will get better actually when we start to add more intelligence into it. Instead of a physician practicing on his or her own experiences, they can practice on the entire organization's experiences because it's all built into some kind of a decision model, right? A decision model along the way, which is great. But again, it'll impact the physician's individual ability to make those decisions, which usually means now you've got some committee of really smart people deciding based on the evidence how we're going to do certain things. So if you think back, pharma used to call on that decision maker, which was now the physician. The decision makers just moved in the organization, so you have to call on them, right? You have to have a discussion with them to do scientific exchange, share with them data about your product, both efficacy and safety, but all the things like total cost of care, how it helps them meet quality metrics, how it may help them improve patient satisfaction. The things are now more important to them, and that's got to be done. That's done very differently than a rep detail, right? because the rep detail was the same message to everybody, maybe a little bit of tailoring. This has got to be based on what I know about the customer, deep needs, deep understanding of their needs, and then bringing whatever that value proposition is. And I think most people figured out that's got to be done with somebody that's got more savvy, more experience, more ability to navigate the system, right? Because it's usually not one decision maker, it's a committee of decision makers as well. And that's where key account management really comes in. And again, just like we talked about how technology, healthcare is a little behind on technology. Key account management's pretty new, other than maybe in the payer world,
Right.
but pretty new to pharma, right? And I know one of the things, having done a lot of homework on this, is that I learned more looking outside of the industry than trying to follow anybody on the inside of the industry, because it's still kind of nascent for us. So.
Yeah, and a couple of things I wanted to focus on.
Yeah.
Number one, the notion of, you said, in the past, but the notion of, well, we're going to have this new model just because we want to get access and we want to kind of go back to the old way.
Right.
Like, we're going to put an account manager in a Banner down the street here because our reps are then going to be able to call on Banner Health Network.
Yeah.
Because once we have these conversations, that's our objective. That's the wrong way to look at it,
Exactly.
right? I mean, that is just
the wrong way to look at it.
Dinosaur thinking.
Yes.
And so if that is indeed the case, I think we both agree on that, what should the overarching priority be when you're looking at these systems? What should they be thinking? What if I'm looking from Pharma's perspective now, right? So what is it that I should be looking to? I'm here in Maricopa County. I want to accomplish with Banner and Mayo and Honor, right? And Dignity. What is it that I should be thinking about?
Yeah, I think it starts with how are the decisions made and where are the decisions made that are important to me. So it's where decisions made to use my product, right? To have my product available, to have it in e-prescribing module, to have it maybe with not, red faces, but smiley faces, or $1 sign versus 10, depending on what the customer uses, right? To drive those behaviors. But where is that decision made, right? And I think it's interesting that people have, kind of started to understand the sequence of it, right? If you think back in the past when payers were new, right? We said, okay, now we know we have to be on formulary. Then we go talk to the doctor, right? Well, there's a new sequence there, which is I would need to be on formulary because the payer has to pay for it. Now I need to make sure that the system values it as much or more than the payer does, and that they have it available in their e-prescribing module, in their protocol, in whatever tool they use to drive physician behaviors. And then eventually maybe still the physician has some choices and there may be a need for a representative, but that's a different discussion, to your point, than it was in the past, where I've got one of many. Why should you choose mine? Mine's one of the three that your organization decided if they want to use in this therapeutic area, and here's the patient they think it's the most valuable for, right? Because we've done this, this, I don't want to use a partnership, but we've done this interaction with your most senior people in medical and pharmacy, right? To show the value where the product's going to work, and they position it here for this reason, right? So it's much more specific of how the product will probably be used, that the representative should be having discussions. And one of the things I've seen too, John, I think it's getting better, but frontline physicians, as we've seen, we're still kind of new into this whole integrated model. A lot of frontline physicians don't even understand why they're being asked to do certain things by their organization, right?
Right.
Because they're still learning and understanding quality metrics and how their organization gets paid. And if the system is paid on value, but they still reimburse the providers on RVUs and, number of patients seen, that disconnect is going to drive different behaviors as well. So
that's critical. That's critical, because anybody who's ever managed anybody else in a business context knows that you have to understand, well, what is that person that you're managing? What motivates them?
Right.
What's important to them? And once you know, or at least have a sense for that and have conversations around that, well, then you can start creating incentives. But if the incentives aren't aligned, if I'm here because I'm a salesperson and I'm part of this organization because I want to self-actualize on sales, well, that's
Right.
going to be a little different incentive structure than ones who say, I want to make a lot of money and I'm going to incentivize you on sales.
Mm-hmm.
And so a couple of things come to mind. The way that my circuitous mind works is one, I think that people thought with the advent of value-based care kind of becoming popular term, and with increased um, health system involvement, health system ownership over docs or
Mm-hmm.
employment of docs. So docs, they're never going to stand for this because they've gone through medical school, they have their way of doing things, and they're not going to be pushed around into following whatever the system says. Well, a couple of things. Number one, back to the incentives, right?
Right.
And to align those incentives, it doesn't matter if you've been practicing for 3 years or 30 years, that if that's where the money, if your compensation is tied to these incentives, and one of those incentives is you have to have X percentage of your patients with diabetes with HbA1c levels at a certain level, then you're going to start paying attention to it. To your point, maybe they didn't learn about that stuff in medical school, but now
Mm-hmm.
they see. Now it's important. The other thing I would point out is, and you've probably heard this or seen this, people coming out of medical school today, and what they want, what their motivations are, is different than 20 years ago, 30 years ago. On balance, not as entrepreneurial focused,
Mm-hmm.
coming out with loads of debt. If the health system can pay off that debt, boy, does that sound attractive to me.
Right. Mm-hmm.
And maybe I'd rather work 8 to 5, Monday through Friday, or have really predictable hours. That sounds good to me for my lifestyle. And so I think that, just overall, the crop of med students coming out these days, not that different from people coming out of college in other areas, and they may have different reasons. So I guess, so my point is, maybe that the new crop of docs that are coming out, they are more attuned to quality and the triple aim and things like that.
Yeah.
They're just, the words being talked about in med school. And if they're paid, they're a Kaiser employee, they're going to follow what Kaiser says.
Right.
And I think eventually, the wisdom of the organization, you have these doctors that say, well, I have my own experience. I think a lot of them start to pay attention to that organizational wisdom. Look, we've been managing diabetes in the following way for the last 10 years, according to these protocols. These are the results. This is what happens when you vary from our established protocols. We have data that shows that. And I think doctors will respond to that. I don't know. What are your
No, I
thoughts?
agree. I mean, I think that's part of what they learned in med school, right? Is it's follow the science, follow the evidence, right?
Sure.
And I think that eventually show them that. And I do think, I remember back when this first started, and people talking about, physicians won't put up with it, to your point or whatever. Well, I think it was a little bit generational, and I think we're far enough along. The fact that 72% of physicians are employees, the ones that didn't want to be aren't or have left. And,
Right.
and to your point, I was reading, I can't remember where I was reading it, just in the last 2 or 3 weeks. Newer physicians actually enjoy not having to manage a practice, not having to be on call every other day, having work-life balance, particularly as we're seeing the balance of more female physicians and female clinicians come into the space. I think there's data that shows they value that work-life balance even more, right? So I
Right.
think that we have got over that hump now. Physicians, I think, are more comfortable being employees. The ones that aren't have probably, in one way or the other, gotten out, either went out, back out and started their own practice or retired or whatever. So I think we're past that now. And I also think that health system leaders are learning that I remember having a discussion with one maybe 4 or 5 years ago. It's like, well, we thought when they were employees, they would follow our direction. So, well, I've been a manager a long time, and they all won't follow your direction, right?
Right,
And to your
right.
point, so now they're aligning incentives, right? And when you do that, people will much more follow the direction. And I think as we see more and more physicians become more aligned to how the organization makes money versus how they used to in the past, you just see the behaviors even more and more get in line with the centralized control and centralized decision making. Because to your point, it's not arbitrary; it's based on science. It's based on a load of evidence. Yes, John, you're a really great doctor, but you've only seen 5,000 patients over your life, and I've got a database with 5 million patients in it, right?
Right.
That can show you that. And they're starting to see the value of that.
Yeah. And to your point, if they did learn that in medical school, right, it's follow the
Mm-hmm.
data and
Yes.
follow the evidence.
Yeah.
Um, so if I'm getting the picture right, Matt, it's that there is a similarity in the 90s and today with account management in the sense that pharma realized that to deal with payers and formularies and contracting and all of that, they needed to have an account management model.
Mm-hmm.
But at that time, it was okay, well, once we get our drug on formulary, then the reps can just handle it from there.
Right. Mm-hmm.
Now in the new system, it's not just that, because 72%, a number that's going to probably continue to increase,
Mm-hmm.
are employed either by a health system or sort of indirectly with private equity. And so now pharma says, all right, well, we have to have the formulary stuff taken care of. We have to have the payer side. And of course, IDNs, a lot of them have formularies as well.
Mm-hmm.
So we have to have that taken care of. But then the conversation changes. Just because you talk to somebody, any doctor at Banner down the street, doesn't mean that they're going to do anything. You need to be focused on the right people to talk to.
Right.
And and so the conversation becomes very different too.
Right. Yeah.
And so much so that I think that the compensation model for account managers is different from what you would see from a typical rep compensation plan, because the activities, the way that they're being evaluated is different. Did I get that about right?
Yeah, you definitely did, John. And I think one thing that was important and that was probably a little bit overlooked. I know we learned it we did the project at my previous company, Pfizer, was you can implement an account management model, and then you've got to find enough people with account management skills and capabilities to fulfill the role, right? And if you think about your current pool, other than your payer people, everybody else was hired to see this doctor this day and say this, right? The old rep model. And so if you think about managing business enterprise management, that's so different than your vast pool of current employees, probably, right? So you've got to either upskill them or go get them somewhere else. And either way, that'll take time, and it's like building in the time necessary to implement a good account management model. I think some companies have not understood how long it would take to do that.
I couldn't agree more, Matt. I think there's a limited supply of experienced account managers in pharma,
Mm-hmm.
and a lot of them came on from the payer side.
Right.
And one of the common themes that I see across our client base is, we need more key account management, corporate account management. We need more, and people being promoted into these brand new jobs, and just a totally different thing. So not having enough supply and then having to train those people. I'd like to take 5 minutes and do a commercial for Darwin Research Group. No, I'm not going to do that. But that's the reality, right?
Yeah.
So there's the need for that training, because there just is a virtual lack of people who have this kind of account management experience in the pharma context. And to your point, and this is really important, it takes time.
Yes.
It's not one of those things that you just flip a switch and say, oh, okay, well, we need to have a new account management team. Let's add 30 people. That doesn't work that way. One thing I wanted to make sure to anchor on, the word partnering.
Yeah.
I swear I have asked this question around partnering thousands of times at this
Hmm.
point in interviews, going back even to the context of when ACOs were first coming out and just thinking about how does pharma partner with ACOs. Um, it's kind of a loaded word, but it comes up all the time. How do we best partner? And so reflect a little bit on that word. Really, what is that a substitute for? What is it? I mean, you kind of answered this before, Matt, but just what's a better question, or
Yeah.
what are they trying to accomplish? And can we retire this word once and for all?
Yeah, it's really interesting you bring that up, John. And so, for full disclosure, John, I've had this discussion before, and I share that with you because I've done a little homework on this and been thinking quite a bit about it. And I think some of it was driven by, it was a really good resource. So I'm not trying to throw them under the bus, but it used to be Health Strategies Group, which is now part of Eversana,
Mm-hmm.
and they used to rank pharma with IDNs, partnering, collaboration, clear down to transactional, right? But they use the word partnering, and I think it became something that everybody aspired to, right? But I was thinking about that, John, before we actually had this discussion today, because I knew we were going to talk about it. So I went back and looked, and if you look at the context of how they were measuring it, it's really important. They were measuring feedback from pharmacy directors and medical directors on, is Pfizer or GSK or Janssen a partner, right? Which is very different than Banner saying that Pfizer is a partner, right? The Banner CEO or whatever, right? And so I think you have to put it in that perspective that, it's within the context. If you want to use that word, you have to use it within the context of where your product fits and the people you're working with, right? Because
Yes.
you're not partnering with Banner or Mayo at the very top of the organization. I don't know if anybody has a drug that's important enough to get a CEO's attention, right, at one of those
Right.
large organizations. But I understand why, a pharmacy director or even a VP of pharmacy or medical director may say, hey, they're a great partner because they came in and they helped us. But I think if I would rather not use the word partner. It's, how do we actually work together on projects that can drive better patient outcomes and then also improve the value of both the IDN or health system and the pharmaceutical organization, right? It's got to be the win-win-win. With the most important, it's got to be better patient outcomes, right? Um, but which word you want to use, I think partnering is overused and it's understood, if that makes sense. It's less
Yeah.
understood than it should be because you're going to do these limited engagements with customers, right? That hopefully have enough traction and value to eventually become part of the way they do business. But you're not going to do it forever. Whether it's improving compliance or it's improving, identifying patients for better outcomes based on some kind of clinical evidence that you've been able to bring to the customer as an example. But I think the partnership sometimes is too grandiose for what we want to have as a goal because it's not going to be that big in most cases. So.
Yeah, and in my experience, when when I talk about partnering with, let's say, a chief medical officer
Yeah.
or the usual suspects that you brought up, pharmacy directors, medical directors, immediately what they think of in terms of pharma is they'll say if they do catch on to the partner term, they'll
Right.
say, well, we have great research partnerships.
Yes. Mm-hmm.
We've been working with them in cancer for 10 years now. We've got great research partnerships. So in a lot of ways, pharma is already executing, but that's not the way that marketing thinks of it, or
No.
that's not the way the
No.
home office thinks of it.
No.
Um, they're thinking more in terms of, rock solid partnerships. And I love that concept of of projects and not partnering, because it puts a defined beginning and an end, or at
Mm-hmm.
least a beginning and a structure.
Right.
Like,
Yeah.
this is what we're trying to accomplish. It puts the patient up front, quality outcomes. So we're talking about the same kind of thing. It makes more sense. And I think back, and I think I've talked about this on the podcast before, but I'll raise it again. I was facilitating a discussion at one of these IDN conferences, and there was um, 3 or 4 physician executives that were on the panel, and we got to the partnering question again. And this one physician executive said, "Look, we only have and this is a pretty big system.
Mm-hmm.
We only have so much bandwidth, and all of you guys come to us and saying we want to partner, we want to partner, we want to partner. There's only so much that we can do. We can't partner with 25 companies. So come to us with a proposal. I'm paraphrasing, but customer focused or patient focused, improve patient care, things like that." And so that made a lot of sense to me. And so what it also got me to thinking is how salient, or let me reword this question. Does it matter if, as a company, you're coming to the table with a robust, diverse portfolio of products and services versus you just have a new rare disease drug? Like, can that company that has maybe their first product or their second, where they're not able to offer what a Pfizer or J&J, or I'm trying to think of GSK, like the AstraZeneca, those with like really big portfolios, is it different for those, or is it the same because you're just trying to move forward with a project that's for that patient population?
Yeah, I think it's the same, John. I think it's the same because if you look at, and I go back to again the good and bad of looking at syndicated customer studies, customer research, right? That Pfizer gets rated very high because they have this diverse portfolio in this diverse number of therapeutic areas, but they're still implementing project by project those initiatives with the customer, right? Whether you do one or many. Now, if you do many, and the VP of pharmacy and a chief medical officer, the medical director hears about 10 of them instead of one, he or she may put more value on rating Pfizer within those rankings. But if you look at what you're trying to actually accomplish, which is creating a project that either positions your product more favorably than it was previously, or helps you find more patients that are appropriate for your product than you had before, that's the same work that's being done whether you work for Pfizer or a company with one product. And in my opinion, and what I've seen work, right? And having worked for both Pfizer and then a much smaller company, we had as much success on a project basis, not overall because we didn't have a $100 billion company, but on a project basis,
right?
As I had seen at Pfizer with one product, with one project, right? So I think it doesn't matter. And then I think in a way, you can actually be more focused because you have a smaller number of products, right? You can be more focused and provide more attention and more value to your customer. I mean, I mentioned Pfizer as an example, and I'm not questioning how they do it. Most of key account management is an enterprise approach, but they can't do that because they have 39 products. Someone can't represent 39 products. So you have 6 different key account managers, mostly not overlapping because they're calling within service lines, but a few times they get overlapping, right? But when you get down to doing that project with the people you need to work with, whether it's in pharmacy or in quality or in outcomes or in data analytics or in clinical, they're different people anyway, right? Depending on your therapeutic area.
Of course.
And you could be just as or more effective with one product as a dozen, in my opinion.
Yeah, and I think it comes down to, really that account manager's approach.
Right.
And I can see why it would be more challenging for them, with why a Pfizer, let's say, it could be more challenging, although they have more resources. And then you run into the problem of, I want one point of contact.
Mm-hmm.
So if that pharmacy director is a one point of contact and you've got multiple people, involved, then I can see how that might also be a challenge as well.
Yeah.
What I'm thinking of, and I don't really have good words to describe this, so I'm going to fumble my way through this. But, I've always said with our small company, with Darwin, For the people who can use our services, and I'm thinking people, not companies, for the
Yeah.
people who, and the ones that I work with or that maybe our account team works with, for the things that we do, I want maybe not my picture, my mug, but I want them to be, when they have a problem that John Marchica comes up, he can help solve this problem, or Darwin can help solve this problem. Not that we can do everything for everybody, but in the areas, where we're strong,
Right. Mm-hmm.
that they think of us. And once, so and so thinks of John Marchica because I can help solve a problem, I feel like maybe we're not partners, but boy, am I getting close to that, because I've wormed my way into their brain and saying, okay, well, Darwin or John or whatever, we can help out with that. We can be that resource for you.
Right.
And I don't know what you call that, but I get a sense that a lot of account managers, the good ones, they want that same thing too, regardless of what company that you're for or you're representing, that you want to be that crucial 2, 3, 4, 5 vendor list of people out there that just comes to mind. I'm going to call Matt Portch because he knows a lot.
Yeah.
Right. I don't know if what you call partner, or even I think necessarily how you can get there, other than project, succeed on the project, deliver what you said that you were going to do, move on to the next project, right?
That's how you do it. It's how you demonstrate it. So, John, one of the things, we didn't use the word partner, and some of it too, for any pharma colleagues that are watching this, is I appreciate and understand 100%. You got to deal with legal and compliance. They don't like the word partner,
of course,
and they don't like the word collaboration or whatever. We called it trusted advisor. I mean, there's probably a better for it, but what we call the trusted advisor. We want your customer, the people you work with, to think of you when they have a challenge in this area, right? They're not going to call you if they need cleaning supplies or,
right.
But some people want to be everything to their customer. And that's one of the challenges I saw, is getting people away from being pharma focused. Don't be overly customer focused either, right? You've got to be customer centric in the areas that you have overlapping interest and resources and tools, right? Not in those other areas. But you want to do that, and how you do that is through demonstrated behaviors. You understand their needs, you bring them a project that meets their needs, you deliver it better than they expected it, and you wrap it up, and then you do the next one. And and in most cases, you work small and get bigger, right?
Sure.
If they never worked with you before, they're not going to do something that may be critical to their reputation or their business. But after 8 or 10 or 12 really good ones, and you've demonstrated over time, every time that you've done that, you might get this huge project, right? But that won't come immediately.
Yeah. And, I recently did a keynote and dusted off some ideas that I thought about 20 years ago, and that aren't particularly unique, but I think that they play a role today. And that is, thinking about trust.
Mm-hmm.
And as an industry, pharma has been at a trust deficit for a while. Some of it justified, some of it not justified. But, when it comes down to it, it doesn't really matter if it's justified. If somebody doesn't trust you or doesn't trust an industry, you're not going to convince them otherwise unless you change your behavior, right?
Right.
And so I thought about this in the context of a very old concept, the relationship ladder, right? So you move your way up the ladder, and then maybe in Pfizer terms, you get to be trusted advisor. In other terms, I've seen champion. We're going to get to the champion level versus just being a vendor, right? So, but if you think about it, as you're moving up the rungs of a ladder, or whatever model you use, you're building trust.
Right.
And you're building trust through behavior, not through words, right? It's through your actions and through how you're managing that relationship and that account. And so in your scenario of small project, next bigger size project, just keep getting win after win, that builds trust,
Exactly.
a foundational trust. And, regardless of the impediments of the home office saying, well, legal, regulatory, and all the things that pharma has to deal with, the constraints around these relationships, that even some of those regulatory folks would say, well, trust is a good thing. And if you're doing things that build trust, then that's probably a good approach.
Yeah, it definitely is, John. I mean, I think if one of the things that I learned over time, if you align it to what people are being measured on, so we aligned everything we're going to do is going to be aligned to the triple aim. To your point, quadruple, now quintuple, and everything we're going to do is to drive trust for the individual and our organization by delivering the appropriate value. Then it's hard for anyone to say you're doing the wrong thing, right?
Right.
Yeah, but even if it's legal and compliance, and so those are the things that you do that, and it's earned. It's that's a cliche we've heard over time, but that trust is earned, and it's earned by how you demonstrate, how you bring value to your customer, and that's an important component for CAM the individual, but for also CAM the selling model, and more importantly for the people who lead key account management and who are looking and having expectations. It's a longer selling, so it won't turn overnight, right? You've got to let it
Right.
happen. We talked earlier about how pharma. I think almost everybody I've talked with now, and I've learned a lot. I worked for 4 pharma companies, but I've learned a lot because I've worked for 24 in the last 3 years, right?
Right.
Everybody, big and small, is if they don't have CAM, they're developing it. But there's been people that have been in and out of it several times. They get in for 6 months and jump out, which tells me they didn't understand to begin with, because 6 months wasn't long enough to even give it a chance.
And it kind of comes back to what I said earlier, having a very short-term focus, which, I can't blame them. I mean, your stock, your shareholders, I get it. But I think there's a way of explaining that to your shareholders.
Right.
In your 10K or in your, like, this is a long-term horizon approach, a long time frame, whatever it is that you're going to say, but really thinking about it. And I agree. It's 6 months, it's a year. We didn't see the results that we wanted. Well, how were you measuring your results? And did you have the right people? Did you have the right approach? Did you have the right strategy? There's a million questions around that.
Exactly.
And, I used to say it was like a pendulum, and like a lot of things in pharma, but this is one of them. Okay, big time focus on health systems and account management model and all of that. It didn't work. Now we're going to go back to the old way. Right. Well, the environment didn't change. In fact, the environment is getting more towards,
even more so. Yeah.
Even more so.
Yeah.
So, well, Matt, I feel like we could continue to talk about this for another hour, and maybe we can do another one at some point in the future. But this has been really great. I've really enjoyed the conversation, and it's a topic that, ironically, I think the first one and maybe the only one that I've done was specifically around partnering. Was someone from your former company.
I watched that as well. Yes, I know exactly
with Scott,
what you're talking
Scott
about.
Hilla.
Scott Hilla. Yeah.
And so for anybody who wants to go back and look at something from probably 3 or 4 years ago, I know it was before COVID, I think that we had that one. It was a very good one. And so it's been great to continue the conversation. Did I forget anything? Is there any final thoughts that you have on Pharma and IDNs before we wrap it up?
I think first off, John, I really appreciated the opportunity, enjoyed the discussion, and as I mentioned, I really do. I have so much interest in this and passion in it, and one of the things too, and I've shared this with you before, that doing what I'm doing now, I have more time to actually do customer research as well, and it just continues to reinforce the need for us, for pharma, to do more and more of this kind of work with our customers, I believe, along the way. And to your point, we've talked about this huge, big thing in a little over an hour, and there's probably 10 more hours worth of discussion that can be had. But I've enjoyed the discussion, and for anyone that's thinking about whether it's tweaking your CAM organization or whatever, I would suggest two things. I'm going to give your organization a little plug. You need to know as much about your customers as possible. And part of why I'm partnering with John is I think their research is as good as you can get to start with, by the way. Then you got to go in and ask qualifying questions with the customers.
Thank you.
And if you're thinking about doing CAM, do it smaller and look for longer versus big and for a short period of time.
Agreed. And I'll add, set realistic expectations.
Yeah. Mm-hmm.
You know, if you're going to get into it, I remember there was a former customer that had brought somebody in. I know I've told you this. I've probably brought it up on this pod before, who said, I don't believe in IDNs. And that's just, that's not helpful.
No,
it's not helpful that, and I get what that person meant. But it's very antiquated.
Well, and based on what's going on today and the environment and the truth as we know it, it's like saying that I don't believe the sky is blue, right? I mean, IDNs, I think we've seen over the last few years, they're here to stay. All of the payment models, mostly run by the government, are set up for IDNs to be more successful and to be larger and bigger, vertically integrated, horizontally integrated. So it's not a trend. It's here to stay.
Agreed. Well, I kind of teased that you and I are going to be working on some things together. I'm going to leave that at that for now. But in the meantime, people know how to get a hold of me. If they want to reach out to you, what's the best way to find you, Matt?
Probably the best way to find me is with my email, portchm@aol.com. Very old school. Excellent. I had AOL back when you had to pay for it. So, but I don't want to lose that.
One of the smartest tech people that I know that works, he's a KPMG. I'll just say that. Yeah. Still has his AOL address, and I respect that guy like crazy. So, way to keep the AOL. Do you still have a disk?
I don't have the disk anymore. No, no, I don't have the disk. And if you don't remember that, I'm sure you can let John know, and he can find me as well. We'll be working together.
We'll make the connection. So, Matt, thank you so much for taking time out of your day and to talk about this. I hope this was helpful for people, sparked some good ideas. And thanks to all of you for watching, if you're watching on YouTube, or if you're listening. Thanks for being part of and listening to Healthcare Rounds. Tell your friends, tell your colleagues. It always helps if you rate and review. That's how people find us. If you don't rate and review, then we sit at the bottom of all the rankings and nobody can see us. So if you like what you heard, please take some time, go to Spotify, or if you're on YouTube or wherever you are, give us a thumbs up. And we'll see you next round. Thanks again.